Hello, everyone, and thank you so much for your patience as we got our webinar up and running here. We apologize for the delay, and I think we're still going to have a great conversation and excellent content to share with you. My name is Rhiannon Clifton. I'm the Senior Director of Testing Operations here at SHIELD. So, we're really excited to have you here. If you have questions, please put them in the chat. And if time allows, we will get to those at the end. First, I want to take a quick moment to introduce our panelists. And I had that open. So we have John Arenas from Illinois Department of Public Health. He's worked in COVID-19 response since the earliest days of the pandemic. Sorry, Alex, I'm going out of order. First with the Office of the Governor and later with IDPH. Since August of 2020, John has been part of IDPH's COVID-19 testing strategy team, managing community testing, mobile testing, and relationships with lab vendors. He has been responsible for IDPH's K-12 testing strategy since April 2021 and has learned a great deal from superintendents and K-12 stakeholders across the state. John is committed to using testing to keep students and staff safe while maximizing in-person instruction. We are also pleased to have Daniel Johnson, MD, Professor of Pediatrics, University of Chicago Medicine, Vice Chair for Pediatric Clinical Services, Chief Section of Academic Pediatrics and Pediatric Infectious Disease, and Director of ECHO Chicago. Dr. Daniel Johnson completed his training in 1986 and is board certified by the American Board of Pediatrics in Pediatrics and Pediatric Infectious Disease. His clinical care focuses on inpatient and outpatient pediatric infectious diseases, and he is a nationally recognized pediatric infectious diseases specialist. He is a professor of pediatrics at the University of Chicago Medicine in the Department of Pediatrics, where he serves as vice chair for clinical services, section chief of academic pediatrics, and section chief for pediatric infectious diseases. He is a member of the Illinois Department of Public Health's COVID School Workshop and educates and advises policymakers, healthcare providers, and school districts on COVID. He is also a member of the COVID Vaccine Scientific Working Group of the Chicago Department of Public Health, advisor on COVID to the Chicago Medical Society, and to the Illinois chapter of the American Academy of Pediatrics. He's published in the area of COVID in schools. He's a recognized expert on COVID-19 and provides COVID-19 educational programming to pediatric providers across Illinois. We also have Awais Vaid, as the Deputy Administrator and the Epidemiologist of Champaign-Urbana Public Health District. Awais leads the agency's strategic planning and operations with an emphasis on systems thinking. He joined the Health District in 2004 after spending a year as a Special Projects Coordinator at the Northwest Community Hospital in suburban Chicago. He received his medical degree from India and his master's in public health from Northern Illinois University, focusing on administration and epidemiology. Awais is a fellow of the Public Health Leadership Institute at UIC and serves on several committees and advisory boards at the University of Illinois and the general Champaign-Urbana community. We also have Julie Pryde, is a licensed social worker and certified public health administrator. She serves as a public health administrator of Champaign-Urbana Public Health District, the CUPHD. CUPHD is a public health advisory board accredited health department. Ms. Pryde earned her Master's of Social Work from the University of Illinois Urbana-Champaign and her Master's of Public Health from the University of Illinois Springfield. She's been published in professional journals and presented at national conferences on topics related to public health. Ms. Pryde began her career at CUPHD in 1995, working with the HIV/AIDS program. She served as the director of the Division of Infectious Disease Prevention and Management at CUPHD until 2007, when she was appointed as the Public Health Administrator. Ms. Pryde serves in advisory roles to the UIUC School of Social Work, College of Agriculture, Consumer and Environmental Studies, the YMCA's New American Welcome Center, and the CU Fresh Start Violence Prevention Initiative. She's a member of the Illinois Immunization Advisory Committee and National Association of City and County Health Officials Zika Advisory Panel. We also have a couple other distinguished guests, Dr. Becky Smith, who is our trusted advisor on all things COVID for SHIELD from the research side. And we have Jeff Aronowski, Executive Director for Safe and Healthy Climate from the Illinois State Board of Education. So at this point, I will turn it over to our panelists, I believe, unless I've forgotten anything. So we'll kick it off with Dr. Daniel Johnson.
All right, am I unmuted now? Can you hear me? All right, wonderful. Thank you very much. So may I have the next slide, please? There are so many different things to talk about related to children and COVID, and of course I will share the floor with the other speakers. We'll go over a handful of slides that are related to the symptoms, feeling that was a good place for us to start. And I'm sharing with the group today some data that was published looking at a compilation of children who came to medical attention across a group of healthcare institutions in the United States. This is not a randomized set. It's children who sought medical attention. And so it doesn't represent everybody, because certainly there's a whole group of children who have no symptoms related to COVID-19. But these are children who either had symptoms and came in to see a provider, or were directed to a provider in order to be tested because they had been exposed to COVID, or someone was concerned about them having acquired the infection. And I think the most important thing to point out here is that there are many different symptoms that people get when they get COVID. And many of them are flu-like. But unlike the flu, the disease also can cause rash-like symptoms, as you can see from the slide. And if you look at the percentages, you'll see that we have some children who have systemic symptoms like myalgia, malaise, fatigue, or fever. We have other children who don't have those symptoms. You can also tell from the data that it's been broken out into children who were hospitalized with their problems with COVID and children who were not hospitalized with COVID. So before going through the details further, I just want to emphasize that somewhere between 30 and 50% of children who get the virus that causes COVID have no symptoms whatsoever. And if we look at the number of children who are hospitalized, it only represents about 1%. Now, of course, that means 1 in 100, so that's more than any of us would like, but it is a relatively small number compared to the much larger group. And you can see here then, after going through the slide, that fever is the most common symptom, occurring in about 13 to 14% of the children who were not hospitalized, and closer to 41% for the children who were. And then there's this mix of symptoms, as I mentioned already, the general symptoms, the dermatologic symptoms, and then some nervous system symptoms, including headache, and for children who are hospitalized, a very small number of them, perhaps because of fever, developed a seizure. Next slide. Looking again at this group, you can also see that gastrointestinal symptoms are relatively frequent for the group of children who are hospitalized with either nausea and vomiting, diarrhea, or abdominal pain occurring somewhere in the range of 10 to 15%. But for the children who are not hospitalized, it's really quite rare, occurring in less than 2%. And then, of course, it's the respiratory symptoms that we think of most commonly to go along with the other symptoms that I've mentioned. And you can see that cough is present in somewhere between 12 and 15%, shortness of breath, or what's called dyspnea, somewhere in the range of 10%. But again, what the data is showing us is that children manage the infection from SARS-CoV-2 very, very well. Next slide. And then there's been a lot of discussion about long COVID or long-term consequences of the infection. And the first thing to point out there is that the average child who has symptoms from COVID will last somewhere between 6 to 7 days. The older the child, a little bit longer, the younger the child, less. But again, somewhere between 30 and 50% of kids have absolutely no symptoms associated with the infection of SARS-CoV-2, the virus that causes COVID. But of the group then who get the infection, there is a small number who have symptoms that go beyond that 6 to 7 days. And so the average child will get about 6 symptoms during that 6 to 7 days if they're going to have symptoms. And then a relatively small number will then have 2 persisting symptoms out to about 28 days, with some going longer. We don't have good data in the United States, but we have relatively good data from the United Kingdom. And this is looking at children who are in England and Wales, depending on which study we look at. For the UK Office of National Statistics, it looked at children who had symptoms out 5 and 12 weeks. And respectively, those were about 10% who continued to have symptoms out to 5 weeks, and about 8% who had symptoms out to 12 weeks. Now, this compares to adults, as you can see there, that about 25% of them will continue to have symptoms out to 5 weeks. And from other data sets, it's somewhere between 10 and 20% that will continue to have symptoms out as long as 12 weeks. This is in comparison to children who do not get COVID, but have other reasons for having a flu-like illness. And only about 1% of them had symptoms that lingered out to 28 days, showing us that perhaps as many as 10 times more children will have long symptoms from COVID as compared to other viral respiratory illnesses. In another study, looking at similar kinds of children, it looked like it was a smaller number, somewhere in the range of around 2 to 5%. So at this point, what we should be thinking about with the long-term problems of COVID is that somewhere between 2 and 10% of children will develop symptoms that last for a long period of time, that 1 to 2% of children with non-COVID respiratory illnesses will have lasting symptoms, and somewhere between 5 and up to perhaps as many as 13% will have prolonged symptoms from COVID. So it's not so much the problems of hospitalization, which represents about 1% or so of children who get COVID, but really the fact that the symptoms linger that causes the majority of frustration from this illness.
If you have questions now, please put them in the Q&A and we will get to those at the end. And now we will turn it over to Julie and Awais.
Okay, thank you. So public health's role in all of this is basically our overreaching goal is to prevent the healthcare system from becoming overwhelmed. And then that will cause, cascading problems. So since the very beginning of this, you heard public health at all levels, whether it's local, state, or federal, putting out guidance to help policymakers, including schools, who are often, our really close partners, putting out different information to help mitigate any type of spread that's going on. What we did at the beginning before the vaccine was different in some ways than what we're doing now. Now that we have vaccines, most of our efforts are now switching over from, trying to protect the whole public, if you will, because people who won't get vaccinated simply are not getting vaccinated. So now we are shifting focus to protect the most vulnerable in our population. And that includes obviously kids who have to go to school. They have to go to school. That is a law. And so we need to make sure that while they're there, they are protected, especially those who cannot be vaccinated. We have to protect the elderly, immune compromised, and individuals with underlying health conditions. So that has been kind of how we have shifted our focus. Next slide, please. Okay. Again, you've noticed things have been changing. Viruses are very smart, whether it's COVID or any other type of virus that we have to deal with. But because SARS is so new, it is constantly changing, trying to adapt itself and to survive. It just basically wants to go from person to person so that it can continue its existence. As the science evolves, you will notice that we are adapting our guidance. So at the very beginning of COVID, you may have noticed that what was being used as guidance was later relaxed, because at first we didn't know, there was a big emphasis on washing down a lot of things. We didn't know if this could be transmitted readily through, fomites or surfaces or things like that commonly touch surfaces. And while it can be, it's not as big of a threat as we originally thought. So then you saw everything switching over to how it can be transmitted and is most readily transmitted, and that's through breathing in other people's germs. So then we moved to masking and distancing. And again, this was all prior to the vaccine. So what our goal is, and you always hear people saying that you have to learn to live with the virus. Well, that's what we're doing. That's what all these different mitigation strategies are for. So the vaccine obviously is key to getting any type of handle on this, but vaccination's key, and then the masking and distancing, the hand washing, all the other things that we've urged people to put into place. So again, our goal is basically to get it to a level where we can all live with it until it turns into whatever it eventually turns into. So, and then Awais is going to talk about what our current cases look like.
Just quickly on the previous slide, wanted to mention that this is our current active cases in Champaign County. And active cases are dynamic, so they keep changing. An active case stays active for about 10 days, and then once they recover, they're not in the active stage anymore. As you can see, a lot of our cases are in the younger population in Champaign County, as expected. But the one good thing is that we are not seeing as many active cases in the elderly population. Again, as Julie mentioned, vaccinations have played a significant role in reducing the number of cases in the elderly population. And I'll show you a slide later where we show the number of vaccinations in each age group as well. So the younger age group, specifically the ones under 12 that are not eligible for the vaccines, are where we are seeing a lot of current cases. It's probably the peak of the infection which we saw in November. We are pretty much very close to that, even though we have vaccines, but the kids are not eligible. So we do hope that we are actually expecting that these numbers will continue as long as the schools are going to be in session. But at least in Champaign County, our goal is to keep schools in session with the conditions that they constantly test. We do surveillance of it. And if we find an issue, if we find clusters, then we will act accordingly. Next slide, please.
Okay, so universal vaccines, more than 90% are, along with boosters, as well as testing and surveillance, are going to be key to what we do here with COVID. As you probably know, being in schools, what we do is we try to find cases, because basically, especially in people who are asymptomatic, those can be invisible, and we need to find them so that they then do not spread and infect people who are more vulnerable, more likely to become hospitalized or have a death. So, we're really, really urging kids in school 12 and up to get vaccinated. We have a decent rate here in our county, but around other parts of the state, it is horrific. And we really have got to get that up, because the younger kids don't seem to have as many problems, but the older kids are definitely, they are definitely getting hospitalized, and there are deaths in that age group too. So we need to keep pushing the vaccination. It is very important. Things we do in the schools, we urge masking, improved ventilation, sanitizing, and physical distancing. That will help break the chain of infections there and limit outbreaks and clusters. Occasionally, we will make a recommendation that a classroom, close down if there are that many people in there, do a deep cleaning, come back after the kids are getting better. Our focus will continue to be on COVID surveillance to ensure there's capacity for the occasional surges. So whereas COVID is not going away completely, we have to prevent this, which we're seeing in other places where the cases just shoot straight up and the hospitals are overwhelmed. Because when the hospitals are overwhelmed, that means that people are going to be dying of other unrelated and treatable issues, whether that's a car accident, a heart attack, something that requires surgery, anything like that. So we have got to try to keep on top of the outbreaks and to keep people in isolation and quarantine, and kind of try to prevent the huge spikes that unfortunately we are seeing in some places. So, and of course, the last thing is everyone will need to take, responsibility and do their part. This is not something that just one group can do. This is not a public health problem. This is not a school problem. This is a worldwide problem, thus the term pandemic.
And just to piggyback on that, look, the chart that I have below is eligible population that have received at least one dose of the COVID vaccine. And the first column over there is the 12 to 16-year-old. As you can see in Champaign County, only about 47% of those that are eligible in that age group have received at least one dose of the vaccine, which in my mind is very low, even for a county like Champaign. And if you see 65 and older population, it's almost 91% or 92%. So as you can see, our cases, which I showed in the last slide, are very reflective of our county's vaccination rates as well. So unless everybody plays their part and gets vaccinated, and not just vaccinated, but also follow the other mitigation strategies, we are going to be in a long haul with this as well. Next slide, please. We'll turn it over to John to talk about testing.
Thanks so much. Really appreciate it. Really only have three major points I want to make today. First, I want to talk about meeting the requirements of the governor's new executive order, particularly for our school environments, where we have teachers are going to be required to test if they are not vaccinated, and then talk a little bit about our outbreak response. And overall, what our goal is here, and just to fit in and with what everyone else has talked about, which is really maximizing in-person learning. So I know many folks, we can just keep it on that slide if that's all right. I think that might be someone else's material. So many folks are really concerned. We are just a few days out from the executive order coming into effect for our teachers. to be required to test if they are not vaccinated. And many folks are wondering, what can I do to get testing into my school as soon as possible? And I know SHIELD is hearing from many, many folks who maybe hadn't considered testing originally. I've been doing this work for some time, and I want to let you know that the best step you can really take at this time, if you want to get testing as quickly as possible into your school, is to go ahead and sign up for SHIELD testing. Because not only will that set you up for really effective PCR screening testing when that's available in a few weeks, but will also help you jumpstart your testing program through Binax Now. That's the rapid antigen test that you can get access to either through, you can do it on your own by procuring a doctor's order and a CLIA waiver, and then receiving those test kits from IDPH, or you can do it through SHIELD. And so doing it through SHIELD is a way to speed up that process and get you testing probably much faster than anything else you can do. If you're looking at, a third party option, that's great. But again, there's still going to be some lead time on that to get started with any organization to do testing. So really one of the best steps you can take today is to go ahead, sign up for SHIELD screening, and then work with them to get your Binax on even faster. Hopefully within the next 2 weeks, you'll be able to start testing with Binax if you're signing up today. So I want to make that point clear, that I really strongly recommend SHIELD as the option to meet the demands in the new executive order. Of course, if you're still saying, but we're not going to do weekly screening testing of our students, ultimately SHIELD's not the best tool for you, and you're going to have to look somewhere else. But if you're considering doing that and need something quickly for your teachers, then the SHIELD is the best option. And we'll talk more about why screening testing is important. But before I talk about screening testing, I want to talk about outbreak response. So unfortunately, throughout the state, we're seeing already, just in the first couple of weeks of school, outbreaks occurring in our districts. And I'm not talking about 2 kids. We're talking about 5, 6, 7, 8, 9, 10, 20, depending on the size of your district, even up to 100 positives in the last couple of weeks. And so that's really detrimental for many reasons. Obviously, we know all the health reasons. I don't think I need to remind anyone here of that. But also the in-person instruction. More positives, more spread in the school means kids are losing out on super valuable in-person instruction, social time with one another, their extracurricular activities, and we want to avoid that as much as possible. But if you're already in an outbreak and you realize that this is happening in your school, what you want to do is you want to minimize the impact, mitigate potential risk, minimize, potentially your entire school being affected. And yes, we've already had schools in the state that are on adaptive pause within just a couple of weeks of starting the school year. I hope that no one on this call has to start the school year that way, and I hope that outbreak testing can be a part of the response there. So what IDPH has funded is for, if you discover that there's an outbreak, in consultation with your local health department, to reach out through a form that I can put in the chat right now, and SHIELD can share, that really provides 2 days of fully staffed screening testing for as many students as you believe might be impacted by the outbreak, and as well as providing that to the households as well. So we had recent guidance from the CDC that we can provide a little bit of community testing in our K-12 environment. So when we see outbreaks, we want to provide that to households as well. So we see this as a really great way, of course, to keep your community safe. That's one of the #1 goals, but also prevent something like an adaptive pause happening in your school so early in the school year. So again, if you're determined with your local health department that you have some epidemiologically linked positives in whether that's a grade, a school, a sports team, we can bring our team as soon as potentially 48 hours to come and get those folks tested. The issue, however, that I really want to highlight for everyone is if you make no preparations and just wait for this to happen to you, and unfortunately, I think it's going to happen at some point across districts, it requires, state law requires that students are consented and their families consent to testing. So what that means is if you're trying to implement this program at the last minute, you're not going to have the time to get all those families consented, and you could delay your outbreak response, meaning you have a bigger problem on your hands. So I highly, highly recommend that if you're saying, I'm not ready to do screening testing, that you're signing up for outbreak testing and saying, I'm going to consent my families, whoever wants to participate, and then they're ready to get tested in the event of an outbreak. Hopefully that does not happen, but of course, with Delta happening the way it is across the state, that it's very possible. And my last point here is about, again, what I've already said. We want to maximize in-person instruction, and screening testing is a way to do that in partnership, I think, with the Test to Stay program. So that screening testing, again, if you're not considering it, that level of testing is what's going to let you know when you have an outbreak before it gets out of hand, right? If you're testing those asymptomatic students on a regular basis, you're much more likely to catch something rather than just testing symptomatic children. I think Dr. Johnson just shared that even less than half of children actually even have symptoms when they have COVID. So unless you're testing asymptomatic students, you're not going to be able to know how COVID is spreading through your school. And then that in partnership with the Test to Stay, which again, we think on testing days 1, 3, 5, and 7, probably using a rapid antigen test that Shield can help you get is really the best scenario to make sure that you're maximizing in-person instruction and letting kids back in the classroom when the risk is low. As many have said already on this call, what we're trying to do, and it's a very difficult task across schools, public health, and a nonprofit and a university like Shield, is to decrease risk, but maximize in-person instruction. So that's a fine balancing act. So in some cases, like when you're going through an outbreak, Test to Stay may no longer be appropriate, and also always in consultation with your local health department. But again, these tools are things that we can help you set up, and it's going to really be a lot easier to use Shield than to, for example, I know some districts are doing, say, an antigen screening system on their own. That's okay. I support that. But that's much more difficult to track. No one's really helping you do it. You're responsible for all the reporting. And it's just not as strong of a mitigation layer to be doing Test to Stay on top of. So again, IDPH is here to help you maximize in-person instruction this fall. And screening testing is really the best way to protect your school and maximize that time. That's all for me.
Thank you all. We've got some questions from the audience. So if we could, we'll start going through those. So for Dr. Johnson, my children have both already had COVID in the spring and recovered just fine. Shouldn't that give them natural immunity against another infection? Can you discuss that a little bit?
Sure, that's a great question. And I'm so happy to hear that they managed the infection so well. That's great news. So one of the things that we know about COVID now is that, like so many viral respiratory illnesses, the immunity from natural infection is incomplete and eventually wanes or disappears. So the question always is how long does the natural immunity to infection last? We know that in nearly 100% of people, the immunity will last at least 3 months. In about 80% of people, the natural immunity will last about 6 months. And then after that, it begins to slowly drop. So it would be about a flip of a coin, let's say, once you get out to around 12 months. And this is the reason why we're recommending that people who've had COVID in the past get immunized. There is a significant amount of data now that shows that individuals who had COVID and then get immunized actually show a remarkably strong response to the vaccine, meaning that the antibody response that they generate, which gives us some clues about the degree of protection due to the vaccine, that their antibody response is in fact stronger than individuals who just got 2 doses, let's say, of the Pfizer or Moderna vaccine versus the individuals who have had natural infection and then get 1 or 2 doses of the vaccine. Their antibody levels are stronger, higher, and at this point, I can't say whether they necessarily persist longer, but if they start out higher, our expectation is that they will persist longer. So I urge someone who's gotten infection before to go ahead and get vaccinated again.
Thank you very much. The next question we have is for Julie and Awais. Why are vaccination rates lower among younger adults, even though it's free and available to all?
Well, that's a wonderful, that is a wonderful question. There are a lot of reasons. We have heard all kinds of things. A lot of it really honestly gets down to disinformation, misinformation. There is a lot of stuff out there that is just flat out wrong. And, we do try to get it out to places where it's most convenient. We offer it, 7 days a week. But there's also, there's a certain age group, as you all know, that are believe themselves to be invincible to most things in general. This just being one other thing. So I think that's part of what the problem is.
Just to add to that as well, if we look at our data, even in Champaign County, we will see a higher uptake in the micro-urban area of Champaign-Urbana versus the more rural areas of Champaign County. So that also plays into the factor. I also assume, and I don't have the data in front of me right now, but parents who have not vaccinated themselves may not be willing to vaccinate their kids as well. So that does factor in as well. And we do have a little bit of evidence that some, racial demographics also have a lower uptake than others.
Thank you so much. I think, John, you might have answered this, but just in case people didn't see it, on the test to stay, could you just explain that a little bit to the attendees here? So the question was, I don't understand the rationale of test to stay on days 1, 3, 5, and 7 when testing on day 6 allows a return on day 7. So why not test on days 2, 4, and 6?
Yeah, I think it's a good question. Also, I think I assumed that this audience was a little more familiar with test to stay, but you may not be. So I'll just back up. So this was really developed in June and July as a way, again, to maximize that in-person instruction, to think about how do we mitigate the risk of a potential exposure, but not confirmed. And so what this was based on was what the state of Utah has done in the last year of their own test to stay, and using antigen tests in what's called serial testing or repeated testing to make sure that individuals remain negative. And so the evidence that we have indicates two things. One, I'll say the 1357 is what was tried in other states. So our epidemiologists were careful to follow the same cadence as what we had some evidence of working. And then secondly, the reason that you do those multiple tests is because the antigen test is not quite as accurate as a PCR test. And there's evidence that repeated testing with that antigen test increases the likelihood that you're going to make sure that you're getting a positive result if someone is indeed positive. So when you ask about that day 6, day 7 question, that day 6 requirement requires a PCR test, which is what Shield can offer you. So they can help you do it that way. But again, at that point, that student would have been out for 5 days before they could even get that test and come back to school. So this was a way to make sure that the student could stay in school and stay in their activities. It's not perfect. None of these mitigations are perfect. We're doing our very best to maximize the amount that kids can stay in school. So we want to make sure that everyone is safe, and test to stay is a great way to do that, but also get kids back in the classroom.
Thank you. I appreciate it. The next question in the chat is for Shield testing, parental consent is required. So the question is, can a district use parental opt-out rather than requiring, active consent? And I can certainly help take that one as well. Yes, as long as the district and any legal counsel are okay with that. We actually recommend that. We recommend an opt-out consenting strategy to get as many of your students consented as quickly as possible so that the testing can be more effective. And John or Beth or anybody, if you want to weigh in on that. Okay. And then what is the recommendation for timing between COVID vaccines and other vaccines or the flu shot?
You can get them at the same time. There's
Okay.
no need to wait between.
Great.
There was a period of time when the CDC was recommending that there be a delay, but now that there's been enough data gathered, around immune response to the vaccine, the CDC made the recommendation that it was no longer necessary to delay.
Thank you. And then the last question, and I may be misunderstanding it a bit. Describe the actual antibody test. Is it a saliva test? So the Shield deploys to COVID Shield saliva-based PCR testing. And then we also have partnered with IDPH to provide Binax Now, which is an antigen test. So we are actually, through our partnership with IDPH, able to provide both of those. And there's different recommended cadences, but I'm happy to turn it over to Beth or anybody else if you want to talk more about the test.
Rhiannon, I think you answered it great.
Thanks. And then I think we talked about that one. And then to Dr. Johnson, have we seen any, I think we already did that with the all-day masking, any risks to kids who wear masks all day? There is another answer that Dr. Johnson provided in the chat about that, but if you want to talk about that, maybe just for a moment.
Sure, happy to do so. So there has been questions raised as to whether or not there may be social consequences, behavioral consequences to children as a result of wearing masks all day. And so far, it's an open question, but one that behavioral and developmental pediatricians are seeing that children are just picking up on different cues. So no longer are they only cueing in on people's faces, the lower half of their faces, but rather they're also cueing in on the upper half, namely their eyes, as well as their body language. And so leave it to children. Necessity is the mother of invention, and they've been able to pick up on other cues, so that right now we don't have any data to indicate that there are any significant developmental or behavioral consequences as a result of children seeing other children or adults wearing masks. The other question that's been raised is around language acquisition, because for some children, they really need to see a person's mouth to help them formulate words. Too soon to answer the question on this one, but I think that's still very much an open question as to whether or not there might be some language delay as a consequence of all-day masking. We'll have to see how that goes.
Thank you, Dr. Johnson. The last two questions, just want to be aware of the time, and thank you everyone for your patience. But the last two are, what do we know yet about the severity of the disease with the Delta variant versus previous variants? And then are there any common comorbidities for the children who have been hospitalized?
Yeah, I'm happy to at least start with that one, with both of those questions. So in terms of the severity of disease with Delta versus previous variants, Delta is definitely more contagious than the previous variants, somewhere between 1.5 and 2 times more contagious compared to those prior variants. But it looks like, by and large, the disease illness that it causes, particularly in children, doesn't seem to be significantly different. There may be a slight increase in the number of children who have been hospitalized with Delta, but there's other data sets to suggest that it's about the same. So I don't think that there's any significant increase in the degree of severity. And then the question around comorbidities for children who've been hospitalized, yes, the comorbidities are very similar to what we see in adults. So if you have an underlying immune problem, particularly with the ability to formulate antibodies, then that leads to some increased risk of being hospitalized. But the bigger problem has to do with obesity, hypertension, and diabetes, which all of those increase the risk of a child being hospitalized. The other grouping in children that we don't see in adults as much is if children have developmental problems where they have trouble controlling their airway. So they may have problems with difficulty swallowing or the occurrence where they're frequently choking or aspirating. And under those circumstances, that also increases the risk of being hospitalized.
Thank you so much. And unfortunately, we're already over, but I do want to thank our panelists one more time. Thank you for being such great partners to SHIELD and for your time today and your wisdom on this topic. We really appreciate it. I know there's a lot of questions around that. And thank you to our attendees. We appreciate your time and your patience as we worked through our Zoom wrinkles, and we hope to see you back next month. We'll have more information about that very soon. Thanks, everyone. Take care.